this is after 3 months we are meeting. I think the last 3 months after launching the laser, we thought we have to bring Dr. Professor Wacinski and enhance the skill. But good thing is that when we had been seeing some of the past 20 plus cases. The number of cases what happened here is in par with what we have seen in Medanta, some of the top centers in US. So I think already you have established the therapy. And also one thing which we have understand after launching laser, especially in Aruna Cardiac Center, first and foremost, I just want to insist, we launched laser after post-COVID, just last 2.5 years we are promoting it. In India around we have 60 plus installation. In Tamil Nadu especially we hardly have 5 installation. And the Aruna Cardiac Center is the 5th installation. And not even this Apollos or any big centers across. I think you are setting a referral base for the South Tamil Nadu. That is a big thing. I also understand from many of the team members while talking with some of the people, last 3 months, the complex procedure, especially when people are referred for CABG, most of them got converted for laser and people could be able to get a minimal access and get discharged same day or next day because of the laser presence in the institution. And I also appreciate doctor because when we travel across India, even yesterday we were there in Kerala, the laser therapy they charge around 2.5 lakhs, but I think you made it very, very affordable for the patient. You make it whatever fits in their bill. I think that is huge compliment for the people around who is coming and benefiting in your institute. Really appreciate that, and I think we were also thinking that that's a support. I think we should not restrict with Medanta or Apollos. So there will be more support given from our side to you to fly this kind of therapy. So really appreciate that. And maybe now I just request you to just come and share some of the best practice what you have been doing. And just please just take the presentation, sir. One doctor. Maybe I'll just request you to call it, sir.
Good evening, everybody. First of all, I welcome all of you for this Indo-Polish laser symposium, which is first conducted in our city. It's a really honor to have Prof. Wacinski all the way from Poland. He is one of the global experts in laser for the past 20 years. And he also is a chair in the Department of Cardiology, Hemodynamic Division, Lublin Medical University Hospital. He has published more than 70 papers. He is much interested also in IVAS, FFR, OCT, tower, mitral clip, and also in laser. And really it is a honor to be with you, sir. And today we heard morning 2 interesting cases at Aruna Cardiac Care. One was a fully 360-degree calcium, a lady lesion, which was very tough to cross with balloon, and second was a ISR, instant restenosis. And we have just reached around 20 cases in past 3 months with laser, and most of our cases are instant restenosis, balloon non-crossable lesions, and acute thrombus. These are the 3 subsets which we are much used in this among the 20 cases. We are in the learning phase, and really we got today a good inputs from Prof. Wacinski regarding this thing. So thank you, sir. And I just call upon next Dr. Ravi Edwin, sir, to come. He'll be presenting his interesting how he approached this acute coronary syndrome. Sir, CDs. Okay, then the CD is getting ready. I invite Dr. Alan Benny. He is Associate Professor at Tuticorin Medical College. He is a young and dynamic interventional cardiologist. And so I invite Dr. Alan Benny to present his approach to thrombus lesion in acute coronary syndrome.
Ready then? Yeah. Good evening, everyone. I thank you, sir, and the organizing team for giving me this opportunity. I'll be presenting just 2 cases which I've done recently. Having a difficult time with the thrombus. 50-year-old male patient, obese patient, had chest pain since night 2 a.m. Landed in a nearby hospital morning 9 o'clock. EKG showed anterior myocardial infarction. It was a non-cath lab hospital. So the duty doctor just transmitted me the ECG. I advised thrombolysis. They thrombolized with retiplase. During the first dose of retiplase, patient developed hypotension, cardiac arrest, VF, incessant VF. Shocks were given, CPR. Rhythm came back. Then within 30 minutes, second dose was retifuse was given. Still, patient suffered and went into a complete heart block. No ST resolution, ongoing chest pain, hemodynamic collapse. Echo showed, by the time I reached there, patient was like sinking. EF was 30%, hemodynamic shock. Advised rescue emergency angioplasty. Patient was shifted to a cath lab hospital nearby. Yeah, this was the angiogram. Okay. Proximal LAD totally occluded. LCX minor disease, Ramus minor disease. Right coronary artery, discrete tight lesion in the mid-RCA. So we planned for angioplasty. I wired the diagonal. I could not wire the LAD initially because it was not visualized. Pre-dilated slightly, and then I got the LAD, wired it again. It showed a tight lesion in the distal segment. I just dilated with the 8 mm balloon, only the tight lesion part. Thrombus was not disturbed much. This was the shot following the pre-dilatation of the tight lesion. Sir, what will be your approach with this case next? How would you like to go ahead with this case?
Thank you. No, it's a very interesting case. Really, it's a two big vessels disease, LAD and RCA, very big RCA. Of course, here it's a very tough lesions. You have a lot of thrombi inside of LAD, proximal LAD, and also I see there is also calcifications in the proximal part. I think if you can go with a balloon, you can go with a balloon. But of course, we are on a laser symposium. We can go with a laser as well.
But it is not available.
Yes. Why? Because first, laser can disrupt thrombi inside of artery, and secondly, we can make best preparation of vessel wall before stenting. It's a proximal LAD. It's a very crucial to be stented very, very precisely and perfect result.
Yes.
But I think that
so
you did very well, I'm sure.
So I gave all the possible medications at this situation. I tried Nicorandil, NTG also I gave, then Integralin was given. Tried all possible medicines. This was the final thing which I could get at this level. So finally I thought, okay, let me fix the lesion with the stent, maybe the flow might improve. So I did not want to disturb the thrombus much, just dilated the spot lesion and then went ahead with the stent. It is a 348 Zines deployed from the ostium, and then post dilated only the lesion site. This is the one happened after that. There is actually no flow. Patient is crashing. Again, I tried all the medicines, whatever that is available. I tried Nicorandil. NTG I could not try. Patient is in complete heart block. So I could not give adenosine. I did not try adenosine. Tried again Fleta injection. We used microcatheter, delivered all the drugs distally, mid-level as well as proximal, throughout the whole LAD. I worked from top to bottom, gave all possible injections, and this is the final thing that happened after all those injections.
Yes, I see. Because the problem is that there is a great burden of thrombi inside of a vessel, and this distal part is completely blocked by the thrombi. And one solution, as you said, is to give adenosine, but the patient was in collapse and block. Second, you must try to disrupt this thrombi inside of a vessel. And of course, as you mentioned, laser is one of a good option in this case, and I will be very happy to see your results.
So this is how I left the lab. Gave all the medicines using microcatheter, all possible things that were available in the lab. Everything was tried, everything given. Did not do much. I could not do anything much actually. And then we took the patient out, kept the patient on Nicorandil infusion, continuous infusion for 3 days. His BP slightly started picking up at this stage. So with dual anatropes and microvascular dilators, continuous infusion, we kept the patient on Nicorandil for 3 days, continuous infusion. And then this was the check angiogram after 3 days. Patient got stabilized, weaned off all inotropes, and started him on Prasugrel, and then discharged home after 1 week of hospitalization. Luckily, he survived. That's what I felt. So,
I think that's a lot of problems. First, this patient was arrived to your hospital already with a big problem because it was failed thrombolysis. Secondly, I don't know how it will be pre-treated before arriving to the hospitals. We have had quite a lot of cases like that before. Introduction in my country of a special system for patients with STEMI. Let's say if you have a STEMI, just ambulance arrived and received the bolus of heparin or heparin subcutaneous low molecular weight heparin, as well as ticagrelor and aspirin. After we observe that this kind of situation is much more less frequently. Maybe it's a reason why in my country and other countries in Europe, integrilin and ReoPro is not available. Mm-hmm. But in this case, exactly what I said, if you have such problem, I propose in the first case to try the laser. Why? Because when you see here, can I try to show you? Because the problem now is very big. If you see here, distally there is no small parts of arteries. It means that this part of artery is closed. Let's say there will be very big infarctus here, and I have just the doubt that it will be lost, that the big part of muscles. I think, of course, you did very well. You try ReoPro, you try integrilin, you try all things what you have, but in this case, it's a case of a timing. I don't know how it was long, this myocardial infection before to arrive to a hospital. I suppose that it was quite long. I don't know, but you know better.
The time window was actually like 6 hours, sir.
6 hours.
Sorry,
yes,
8
it's
hours,
okay.
8 hours.
It's okay, but okay. It was a big problem, big plaques and big thrombi. Altogether, very bad situation. But I think laser in this situation is very
might have
effective.
helped a lot. Yes.
Yes, okay.
Would it be a dissection?
Yeah.
There is a hazy area there, no? Medial lady.
Yes, of course.
This part? No. This,
No,
the medial
proximal part?
medial lady.
Middle AD.
There is a
Yes.
haziness,
No, but you know, when you come back to the previous slide with angio, when it was just open it, you saw that here in the proximal part it was the huge plaque and huge thrombi inside, and this thrombi was probably going downstairs and just. Just closed all microvascular, and there is no out for blood, and it was TIMI1, TIMI2, etc. And I think the problem was before just a thrombi. You had two solutions. First, the most simple, but not proven, is to make atherectomy by aspiration. It makes sense, in my opinion, makes sense, but unfortunately, in the studies, this approach was lost. Okay, probably why? Because it was used too late. If you have aspiration atherectomy in a patient with STEMI after a few hours, this vessel is already blocked distally. It's gone. Here, if you are very early stage with a thrombi like that, you can try laser if you have laser at your hospital, because laser can disrupt into the very small particles this thrombi. I know that in India you have a lot of patients like that, and I think it's a good solution for you. Instead, I just propose to let's thinking in the future to make similar like in Poland a system which is one of the best in Europe actually, pre-treatment of a patient before hospital arrives. For example, I don't know, probably in ambulance you don't have doctors, you have only paramedics. In this case, we have also the same situation in majority of our ambulance, just to try to make, maybe in a state, maybe in just this region, to pre-treat with patients. If you have a proof that it's a STEMI, just try to make a transmission to the cath lab, just to prove, okay, it's a STEMI. Just give them aspirin, ticagrelor, and small bolus of heparin. In this case, you have 1 hour to go or 2 hours to go to the cath lab. You have already patients pre-treated, okay? And you will see that will change dramatically the case like that. It's very nice case, excellent case, but you know, it's dramatic case.
Can we take thrombus-suction catheter inside and give drugs?
Yes, of course.
Sometimes it works out.
Yes, of course. Yes, of course.
Actually,
Yes, of
this case was
course.
done like that. I did not use fine cross. It's a thrombus which I used to deliver the drugs from top to bottom.
By fine cross, no, fine cross you can put, but it's too small. It is too small. You must have a large bore catheter, you know. And the problem is that anyway, a lot of you push forward, and it's really difficult. But with laser, you can disrupt it into the small particles. And if add, for example, integralin, it helps to re-establish macrovasculature distally. Okay, there is no 100% technology, 100% situation. I think it's a better, like in other medical situation, it's to avoid situation like that. Avoid, it seems, to give pre-treatment already at a place where the patient is find it, you know. It's like that. I think it's very important for doctors outside of a hospital, no inside hospital, because you know your job. If somebody comes, you know. But the doctors outside of hospital, referring doctors, must be included into the treatment of a patient in STEMI, like partners, just to give a treatment go to the hospitals, nearest hospitals. If there is no possibility to go very quickly to cath lab, okay, you can give also the thrombolyze, but directly go to the hospital after. It's really archaic, because why the thrombolyze could be failed in this situation? Because, okay, thrombolyze just act very quickly, no aspirin, no ticagrelor, and after it will be closed. It was reclosed probably because it was failed. Yeah, it was starting to be patent, and after 1 hour or 30 minutes, it went when thrombolyze stops to act. It's reclosed. It's just we have observed it the same in my country. Really the same. When we have started with this program, it was 2001. We have had the same scenario like you have here. Really, no cath labs, very few cath labs, 24 hours, 7 days per week, and of course no pre-treatments. The patients were coming with STEMI after 1 day, 2 days, 3 days. The same scenario, really. Just reconsider. It's just my advice. It's not costly program, really.
Sir? Okay, sir. So I'll show one more case. 50-year-old male patient, chest pain 3 days. Distal dysfunction, dissertation. Angiogram, LAD diffusely diseased, 70 to 80% in the proximal to mid LAD. And then LCX, major OM ostium has 90% stenosis, calcified disease. And this is the RCA, totally occluded. Yeah, this is 3 days old MI. Patient had ongoing chest pain, so we started. Here I tried 3 runs of thrombosection. Since it is a late presentation MI, I thought the thrombus would have more been organized, so tried 3 runs of thrombosection, and then gave slight predilatation, and all the drugs were given. Still, even after 3 runs of thrombosection, I could not get a decent flow in the RCA. So this was actually a run of thrombosection, which I 3-4 runs of thrombosection done, but not much of useful. The yield was actually very poor. Nothing came out much actually. Then I stented the mid RCA, 3.5 24 Zymes. So this was the final shoot. Not much happy about it, but this was the one I could achieve after like 1 hour. All the drugs were given, pre-meds were given, all antithrombotic medicines were given, integralin tried. This was the final thought.
This is before?
No, sir. Both are same. Just angle. Yeah.
Did you perform some check with OCT or IVUS?
No, sir. I don't have imaging there.
Yeah. My proposition is toujours. Okay, toujours. I speak too much French last week, and I apologize. I think that the problem is, in this situation, probably you have left some dissection before or after the stent. You don't see it on angio, but you will see it on IVUS or OCT. Very good. In such scenario like that, okay, I'm with you at the cath lab. After your stenting, I put my OCT or IVUS always, just to be sure what happens, because sometimes it looks good, but sometimes distally you have left just, or proximally or distally left just a little bit dissection. Over this dissection, it produces the thrombi produces the thrombi, etc., 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 and you have TIMI1, TIMI2 flow. It's like that. It's a most possible scenario like that. Always, if you have a problem, don't panic. First, make a statement what's happened. Put IVUS or OCT. It's up to you. If you are much more familiar with IVUS, go with IVUS. You're much more familiar with OCT, go OCT. But you must know what's happened, okay? Integrulin, it's only for a short time a solution, you saw. You know it very well, n'est-ce pas? And I think that this, it needs visualization. In my opinion, if you have a tough case and even the easy case, but it turned something wrong, always you must understand what's happened. Because otherwise we are, I don't know, really, I don't know.
No clue.
But you agree that visualization is a crucial action. Exactly. Today we have made two very nice cases, tough cases, but we have saw some small dissection. You must you change a little bit the stand into the right place because of a small dissection which is not visible in angio. You agree?
Yeah.
It's just like that. My proposition, excellent case, excellent scenario, but unfortunately, it was not completed by visualization. It's important.
Yeah. Thank you.
But bravo, very good case, very good case.
So that was a nice presentation, Alan. Actually, when you ask any cardiologist what is the most tough, most of them will say calcium arteries. But if you really see, thrombus is the worst thing for a cardiologist to face. Even calcium, okay, that's a different, but the problem with thrombus is the patient will crash or shift into the other thing, complete heart block, hypotension, all these things. Calcium, okay, at least we can defer the procedure and come out if, but thrombus is the most challenging, I feel personally, for a cardiologist, well shown by Alan. So next I call upon Dr. Vijesh Anand, consultant cardiologist from Aruna Cardiac Care, to present about non-crossable lesion scenarios.
screen share ஆகல.
அவுட்புட் சிக்னல் வரலாம். ஸ்க்ரீன்ஷாட் ப்ரொஜெக்ட் பண்ணுறதுக்கு ஏதோ ஆப்ஷன்
தெரியல, என்னோட லேப்டாப்
வந்துடுச்சு. ஸ்க்ரீனில் தான் இருக்குது. டூப்ளிகேட் வேறு கேபிள் தாங்க.
Yeah. Yes. PC screen ఉంది. Good evening everyone. Sorry for the delay. I'll be presenting about the current approach of non-crossable lesions with unique hardwares. So what will we do if we have an uncrossable lesion in our cath lab? So suppose we do an angio. So to be very practical, we'll be increasing the support of the wire. That is, buddy wire will try to put the first step and try to cross the lesion. Second thing is, we will de-escalate the balloon. Suppose if we take a 2 balloon or 1.5 balloon, we will try to de-escalate the balloon to 1 balloon, 1.25, de-escalate the balloon. If that also didn't work, we will try to increase the guide support. So if there is a good guide support, the more chance of a balloon crossing will be done. So we will try to increase the guide support. If the guide support doesn't work, we will try to put a guide extension and give a good backup for the guide. So if there is a wiring difficulty, we will try to cross with a balloon support. That is, we will take the wire, we will try to puncture the cap of the vessel. If it's not possible, we will try to keep a balloon and extend the support of the wire. So the fourth thing is the balloon anchoring technique. And the fifth thing is the balloon small wedge technique. I will discuss about later. And the balloon assisted micro dissection, that is, we'll take a low profile balloon, we'll try to burst the balloon and create a channel, micro channel over it, and we'll be able to cross with the other balloons. The last thing is microcatheter wire exchange, that is, we'll try to take a CTO microcatheter, we'll try to dissect the vessel and re-enter it with a smaller wire. So I'll be sharing few cases which we did in the last year. During that time we didn't have laser, so we had to try with the available techniques, and we'll be discussing what we did and what it happened. So this is the first case, patient named Jiva. He was around 60 years old, male with a diabetic, and this is his angiogram. You can see the left system, LAD and LCX are almost had some disease, minor disease. And the second one is, this is the RCA. This is the thing we encountered. In the mid RCA had a thrombotic occlusion. He presented with inferior wall MI. So we took a balloon and a smaller propel balloon. I think it was 1.25 balloon. I think it didn't cross actually. So we de-escalated the balloon. One balloon we took it, but we are not able to cross the lesion. So as I said, we have put another wire for the support and try to cross the lesion, but that too didn't work actually. So later what we took is a 0.85 alveoli HP balloon. Luckily that balloon crossed. So after that we escalated the balloon and we actually stented the patient. So while stenting, you can see there is very much difficulty in tracking actually. So this was the first case. So if the balloon is not crossing, we will put another wire and try to increase the support and cross the lesion. The second case, he's a 55 years old gentleman. He had a LAD and L6 disease, minor disease, and same RCA is almost acute on chronic CTO. But he had presented with an acute chest pain. The drop was positive. Since considering LAD and LCX normal, this could have been chronic CTO, but somewhere near the occlusion has happened recently. So we tried with the run-through wire, and the wire didn't cross. We accelerated the wire, and the wire crossed, and the balloon didn't cross actually. So we did a balloon anchoring technique. So the other wire has been put into the smaller channel, and then we escalate. We tried to push, but that didn't work. So this was the wire. I think the first wire actually we had a doubt whether it went into a subintimal channel. We can see the second pictures, there was some subintimal dissections noted. So we wanted to cover the stent from distal, and we escalated the balloon, and balloon crossed. So this case we did with a wire support. The second case I showed is we anchored the wire into the smaller vessel, and we crossed the smallest balloon which was available. We stented the vessel, and the result was pretty good. This is the third case. This case also presented with a near total occlusion. It was a recent inferior wall MI, but a very delayed presentation of more than 3 months. So when you took an angiogram, proximal RCA was totally occluded. So this case also we tried with a balloon anchoring technique, and we had a difficulty in tracking the wire itself. And with balloon support, you can see the previous slide. We tried with a balloon support, and a balloon cross. With the balloon support, we crossed with it. So the thing is, first case we tried with an body wire. Second case we crossed it with the help of an balloon anchoring techniques. In this case, we have to use balloon anchoring technique as well as a balloon assisted wire assisted balloon technique, which helped us in tracking the vessel. So afterwards we continued the case with the score flex balloon we dissected, and then we stented it fully. We covered 2 long stents from distal and proximal. The ostium was flat. It's a good result. This is the third case. Saroja with a 60 years female, non-crossable lesion. And the LAD L6 has a diffuse disease, and the LAD had a good collateral with RCA. So this case also we had difficulty in wiring, and the mid part had the disease. But with difficulty we crossed the wire, and wire escalation was done actually. We crossed the wire. So we increased the guide support with an guide extension catheter, and the smallest balloon, alveoli HP balloon, crossed actually. This is sixth patient, Srinivasan, and this case is a recent antral MI. The wire crossed and the balloon didn't cross. We de-escalated the balloon, and the lowest balloon available on the shelf didn't cross actually. So the wire crossed, and we are not able to track the balloon, and finally we left the case and we medically managed the patient. This is another scenario. So this case, Vel Kumar, he's a 74 years old gentleman. He had an RCA CTO. So we tracked the wire without microcatheter support. We were able to track the wire, and Sorry. This is his LAD, and we are not able to cross that CTO lesion. CTO, the wire went up to the mid part of RCA. After that, it now not able to cross the lesion. So we abandoned that CTO and we are fixed the LAD lesion. So this is the patient which we did 6 months back, I think. RCA had disease. We fixed the RCA, and the LAD has a tight lesion. We proceeded ahead with a routine plasty. The L6 had a disease which also been fixed. So LAD, so this was the lowest balloon, actually 1.25 balloon we took, and the balloon didn't cross. We de-escalated the balloon, and even 0.85 balloon didn't cross. We used a guide extension catheter. You can see the guide backing out actually. So we planned with a case with a rotablation. So we took a 1.25 burr, and we crossed the burr crossed actually, and we were able to track the balloon and everything after the rotabur shaved the portion. You can see in the last picture, entire LAD was shaved actually, and finally they had a good result. So you can see that the final results are very good and satisfying. So this is the last case. First 7 cases we did. Out of that, 3-4 cases we are able to track with multiple techniques using the guide extension, buddy wire technique, parallel wire techniques. And 2 to 3 cases we are not able to proceed forward. We failed. And this last case we did with the rota support, and this case we did it with the IVL support. So the lady had a disease, significant 360-degree calcium in the middle. So we used IVL. 3 IVL balloon, and the patient after IVL the balloon crossed and everything happened. We steadied the patient. You can see the dog bone effect in the last second picture. It has a diffuse calcium in the LAD and the proximal LAD. We have to cover the left main also. So we deployed 2 stents. So this is the final result. So to conclude, I will say how to approach the balloon uncrossable lesions. The first strategy is de-escalate the balloon, rupture the balloon inside the vessel. That is, take one balloon, push the balloon and try to be in the lesion as close as possible. Try to inflate it a higher pressure so the balloon will burst and create a micro channel so that we can track the other balloons. So how do you approach, sir? How will be your practice while if the balloon is non-crossable? You had the smallest balloon available that is also non-crossable lesions.
Yes, I have. Thank you very much. Excellent cases. Really, congratulations. I think that you did a great job, and of course there is a different scenario for this such of lesions. Yeah. You have presented it escalation with a small balloon, body wire, ankle wire, etc., etc. You can also try to make contralateral. That's for CTO exactly. Of course, if you have possibility to go with microcatheter, you can cross with wire for rota. It's also one of a solution, but we can see that all these things, what the cases you have made very nicely, and the final result was very good. Congratulations. But if you try to do it with laser, it will be probably much more faster and less complicated. First, we have tried to, we can work together today that when you cross with a wire, simple PCR wire, your choice, which wire you have chosen. After lasing, in this case, it's quite easy. You can go, of course, maybe not too much fast, but maybe steady, but it will be much more faster, and you can achieve just a tunnel for a place for your balloon. Because of course, laser don't conclude all of these cases, but laser can give you an opportunity to predilatate the lesion and can finalizing this PCI with your stand according to your choice. I think it's non-crossable lesions. It's one of the top indications for laser. It's as well good for non-crossable lesions, non-balloon crossable lesions. As well, you have made very nicely here. And I think that, of course, one thing, subintimal technique is not for laser. Yes. Okay, it's not for laser because it's too dangerous. I not recommend. Okay, some people just did it, but I not recommend. Okay. But otherwise, it's a very good choice, and a very nice subjects and very nice cases what we have presented. Congratulations.
Sorry about the power failure. So increase the support. Third thing is increase the support. Fourth, we will use the microcatheter and the wire cutting or puncturing technique. And the sixth is laser ectotomy and subintimal dissection technique. That is, as Sir told, when there is a dissection, the chance of using laser will be nil. So this is one of our technique where we will use the side balloon, branch will be anchored, and we will try to cross the lesion with the extended guide support and everything. So this is another technique. This is that, like, introduce 2 wires and 2 guides. So the red color thing is the guide extension catheter. You need to make sure that guide extension catheter is providing a real support. Most of the times when we introduce the guide extension catheter, we'll try to de-escalate the balloon and push the balloon. The guide extension itself will come out. That is, we took the guide extension for a better support, but it failed to give the support. So you need to anchor the guide extension actually. So through the second wire, you inflate this balloon so that the guide extension will get fixed. After that, you can try to wire the second actual lesion, targeted lesion, and cross the balloon. This is another technique which can be really helpful in difficult scenarios. So this is the wedge inching technique. What it is, parallel 2 wires you may take a larger balloon. So most of the times balloon will balance it will slip out. So even if you de-escalate the balloon and try it with a smaller balloon, the balloon will slip out and it will be jumping out actually. So what you do is take 2 wires, try to cross the lesion. On the first wire, take a larger balloon, and the second wire, take a smaller balloon. So first balloon you inflate, second balloon you deflate. So simultaneously you do both the balloons again and again. So you can, like, inch by inch, you can try to move the balloon. So at a point of time, the lowest profile balloon will try to cross the lesion. This is another technique which should be useful in difficult cases. So stepwise approach is first use smaller balloon wedge technique, what is shown last slide. Balloon assisted microdissections. If microdissections happen, there will be no role for laser. So third thing is try to do with a good guide extension. Even with a laser, there has to be a good guide support with a guide extension. So without guide extension support or thing, even wire, balloon or laser, anything won't be possible. First try to achieve a good coaxial guide support. And the fourth one is microcatheter wire exchange. And the fifth one is laser. Thank you.
So that was a nice presentation, Vijay Shunan. So you have seen a collection of cases, and how with the existing real cath labs we did 2 years, 1.5 years back without laser and all. So it was very nice. So next I call upon Dr. Ravi Winsor, senior cardiologist, Angel Hospital and retired professor and HOD TVMCH, to present his case scenarios in ACS.
Good evening, everyone. At the outset, I thank the organizers for having given me this unique opportunity. Is it?
Directly to computer. Cable. Cable to.
So I thank Dr. Arunachalam for having invited me to give a talk about how to approach thrombotic lesions in down south. Professor Wacinski is so happy to be here, and we are so lucky to have you here to give expert opinion about the cases what we are doing over here. So this is the first case, the handling ambiguous bifurcation lesion. So this is the history goes like this. The patient was an alcoholic and there was no history of diabetes or hypertension, and he was admitted with chest pain, and the ECG showed ST elevation in extensive antrolemma, that is V1 to V6 L1 AVL, and the echo showed hypokinesia LAD territory, and patient had moderate LV dysfunction. Patient was a quite young fellow, 34-year-old. So this is the ECG, what I described previously. Next. So this was the angiogram. The RCA was superdominant, and the left shot showed in the bifurcation area of proximal LAD and diagonal, there was an ambiguous lesion. That was like a thrombus or calcium or anything. So we did an OCT for this patient. Patient was given antithrombotics, that is glycoprotein 2B3A receptor inhibitors, and patient was taken up for angiogram after 2 days. So this was the OCT done. The OCT pullback in LAD showed both white and red thrombus and disrupted plaque and no visible rupture. The lumen area was 7.37 here, and there was nothing but a white and red thrombus there. And the OCT LAD pullback revealed thrombus at the bifurcation point. Next. And the OCT pullback in D1 revealed thrombus in bifurcation point. So having thrombus at the bifurcation point at both diagonal and LAD, so we were thinking what to do. So what could be done in this case, sir? What will you do?
It's a very nice case, very tough case, of course. I think the most simple thing what I can do here, it will be just thrombectomy by aspiration. I think it's the most simple thing. I put 2 wires, one wire to LAD, second wire to big first diagonal, I see, and just remove thrombi. Yes. As much as possible, exactly, and I think it's a first attempt, because otherwise you have only 2 options. First option, it could be give integralin on ReoPro and just wait what happens. And third, laser. But I think the most possible and most practical things, just in this case, it's to put 2 wires, give integralin and try to aspirate. This is not possible to aspirate because probably, as you said, it was a thrombi with several days of formation. 2 days, yeah. I think laser it's a good option. Why? Because you can disrupt this thrombi and to the small particles. But to avoid this distal occlusion, I think that integralin will be welcome for this. It's just my approach if I will have this case like that.
Can I have my... So the LAD pullback showed the MLA was 4.49 and in D1 the MLA was 2.41. So how did I conclude? OCT revealed MLA of more than 2.41 and there is no visible rupture seen in OCT, and OCT helped to defer PCI in young MI patient, and also it guided to understand the pathophysiology for decision making, and OCT addresses the limitations of angio. So the stenting was deferred for this patient. Yeah. So the second case, this was a 61-year-old gentleman admitted on 30/6/2025, admitted with acute inferior MI with post-oral MI. Patient was lysed with alaxim and the echo showed the regional wall motion abnormality, inferior, posterior and lateral wall, and the ejection fraction was 35. And CAG, can I have my... So the CAG showed the left main was, the shaft was 40, proximal OM1 was 40, and OM2 minimal irregularities, and proximal RCA showed total 100% block. So I introduced whisper wire, and the thrombus suction was done thrice. And I couldn't succeed. Then I did ballooning in the proximal RCA with 2x10 mosaic balloon. So after ballooning, I could get some form of flow. So what will you do at this case, sir? Suppose if it is there like that.
It's also very difficult case, but what we can do here, first we must reestablish the good flow, the pharmacology as well. Second, you have your, you must put, you have your wire in place. Yes. In this case, I will try simply with a balloon first. If you go with a balloon, we delayed, put the stand, maybe second lesion below in the middle part, and I think it will be done. If you have a problem to advance a balloon, there is a problem. Yeah, few solutions. First, of course, today we're on a symposium with laser. It's a perfect case for laser. We just, your colleague who is sitting here know very well. You can create a nice passage with laser. First, just to be sure that it's a good passage, and after conclude with a very small advancement of laser. Why? Because with a small advancement, you create the space 3 times greater than tip of a catheter. With 0.9 catheter, with the most use for such cases, you create up to 2.7 millimeter space. It's enough space for ballooning and for put the stent. I think it's a good solution. If you don't have a laser, what you have? Microcatheter, rewiring, rota, but in this case you will have a lot of debris from rota, and you will have no reflow 100%. I think laser it's a good solution for this case. Yes, it's just my advice.
Yeah, what I did was I did a ballooning in the proximal area, and I covered both the lesions, proximal and mid lesions, with a stent. So this was the final result. Yeah.
Yeah. Excellent. First choice, balloon. It's going, balloon. It's perfect always.
So we didn't have laser. So now laser is available. Yes. I think we will be comfortable with the laser now.
Yes, because you made it excellent with balloon, but in such several cases it's not crossable with a balloon, because sometimes it's calcium. It's really difficult to cross with balloon. Of course, after 1 hour of try, you can cross, but the problem is the timing. You have the patient with a STEMI. Yes. In my opinion, we must choose the situation when you can conclude your procedure as faster as possible. Okay. Why? Because, as you know very well, if procedure is longer, it's much more you are not much more faced with some complications. It's a shorter, it's a better for patients. I think I try to choose the most efficacy solution for a patient. Hopefully, you have made excellent job with a balloon, and after put the stent. Perfect.
Yes. So how common is slow flow in lasers? Suppose if you do laser,
yes.
Is there a chance of having slow flow in laser?
Excellent question. Just to compare with rota, because rota laser we can compare. With laser, the no reflow phenomenon is dramatically lower than in rota. Why? Because with rota we produce a lot of debris which is going to the distal level. Yes, and microvascular closure is an issue. With a laser, you don't have this kind of debris, because first, the majority of thrombi is vaporized. Yes. It's just a small bubble of gas. It's not close the artery. And the second, there is no debris like with a rota, and finally less TIMI flow 1 or 2. What could you happen with a laser? Of course, we can make too much energy. You can have, for example, a contraction of artery. Okay, it could happen like with other PCI, but you can give simply nitroglycerin. It's out. But TIMI flow, of course, could be diminished. No reflow you can be happened with laser as well, but very, very less frequently compared to rota.
So suppose if you are not able to cross with 0.9, what will be your next approach? How will you escalate the next? How will you pass laser?
Yes.
Yeah,
yes,
you have three things, no? 0.9?
Yes. We have 0.9. It's the most popular. Yes. 1.4 and 1.7. It's for coronaries. Yes. But 0.9 is the most popular. Why? Because we show you during my presentation that it's much more powerful, more versatile. It's going with a very big tortuosity. It's a very nice profile to compare with like a balloon, NC balloon 4, let's say. It's a very nice profile. 1.4, it's also good, but it's less flexible, much more stiff, and it works. It's 6 French, but if you are dealing the procedure with for example, extension catheter guideliner or something like that, it will be impossible to do it with a 6 French. You must switch into 7 French. It's better because there is no such space. 1.7 is not used, it's accidentally used really, because it's a big catheter. We use 7 French, but you must keep in mind one thing. You have tip of a catheter just behind of you.
Yes.
When you are crossing the lesion with a catheter, very slowly you can make the passage 3 times bigger that catheter tip. If you have catheter 0.9, you can create 2.7. When you have catheter 1.4, you create 4.2. If you have catheter 1.7, you can create 5.4. You know, it's a huge artery you need to do. It's a reason why before, in 10-15 years ago, the people use, myself also, the bigger catheter, because we thought that, okay, we just remove all things to removing. But with this approach, we have had a lot of complications with perforations also. It's the same for a rota. Rota 10 years ago, 15 years ago, we've used rota with a big bar, 2.5 starting.
Yes.
And now 1.25. What, you know, less complication, less perforation.
Yes.
It's my response.
So can you combine both the thing? Suppose if you are not able to cross, can you do rota and then laser? Can you combine both the procedures?
Yes, opposite. Sometimes when I did not use contrast mixed,
Yes.
because it was forbidden, let's say, I try to do it with very tough lesion, very complex and very calcified lesion like that. First, I make a passage with laser, and laser itself with saline, it don't create such much energy like with contrast mixed. And in this case, I try to do with razor technique. Let's say after lasing, I created the passage. I put normal rota wire and conclude the intervention with rota wire. But now it not makes sense. Why? Why to use 2 expensive tools and it prolongs your procedure? Now just try what we have done with your colleague very successfully. We have escalated from saline up to blood and up to contrast mixed. And this very tough lesion, 360 degrees, we have achieved a good result with contrast mixed because we create energy up to 120 bars. What it means, it's a 2.5 double of IVL. It's a question energy.
Yes. Is there any contraindication for saline lacing?
For saline lacing, no, because saline lacing is very safe. One contraindication is the sizing of artery. I not recommend to do lacing below 2.5 for the reason what I described. 3 times laser tip,
yes.
you know. Below 2.5, no, but 2 point or more, yes.
Thank you, sir. Thank you so much.
So, please, sir. You just.
Thank you. No, that's a pleasure for me. Really, thank you.
Next, Alan Benny, please.
Thank you.
Sir, உங்களுக்கு
Yes.
Vijay.
Congratulations. You are very good.
So after hearing all these things, I'll just go through fast few cases and then hand over to Professor Wacinski. Slide. So in some, I will be talking on thrombus lesion, one ISR and one calcium. This is one 79-year-old diabetic patient who presented with STEMI in Sankaran coil, lysed and transferred here. He had a moderate LV dysfunction. And this is the right system was okay, left dominant. And you can see that there is a good tight lesion in the proximal LAD, and distally the flow is not that much good. So he has a 79 years. So the thing is like what Alan was presenting and also sir's second case of Ravi Edwin sir. So if we dilate, the thing is lucky to get the flow. Most of the time you'll end up with no flow, slow flow in chronic thrombus patients. So what we did is we take a laser 0.9 millimeter catheter. The advantage is 79 years we expect calcium with the thrombus. That's what the thing. So if we just put a stent, you'll get unexpanded. You'll be trouble. If you dilate aggressively, you'll definitely get a slow flow, no flow, VF, arrest, all these things. So the only calcium modification device which is indicated thrombus, acute on chronic, that is calcium, like in the elderly, 79-year elderly who had a thrombus, STEMI, this is the safer because we cannot use orbital atherectomy, rota in these situations. It's very dangerous. So we took a 0.9 millimeter, did a saline lacing, and then followed by that we did a imaging. You see that there is some work is done. You see that some cuts are all done, but still you can see in these places, these are all the shaving is done with laser, but still after that you can see one area there was full calcium 360 degree was this place. So you can see it here, and what I felt is that is away from the lesion area, but the lesion area is given in the orange arrow, but the second bookmark what you see is the 360 degree calcium. This is the thrombus lesion. So we did lace in that area, and we did a spot this place. This is a lesion place, this is calcium. So I just again lacing done, and after that we just dilated that area with scoring balloon, and then stented distal one stent and proximal another stent. No pre-dilatation. You just see that no pre-dilatation except that spotted preparation with balloon. So this is the final result. So it was very nice, and you can see that compare the pullback, and there was some under expansion shown by Ultron software, and then that was post dilated. You see now here there is a critical lesion is there. So we were not able to see this tight lesion initially, but there was slow flow down. So if we had done aggressive pre-dilatation looking at 79 years at the lesion area, definitely that would clog this branch, and what Alan was showing now, we would have developed full no flow, slow flow, and we will be in soup in spite of aspiration. So that's one advantage. And next case is a ultra-local balloon non-crossable. This is a 75-year-old male who undergone a angioplasty previously in 2016. EGFR was 36 ml. And this was you can see that RCA totally occluded at the stent, and the left system is fairly okay. So we tried, this is a guide liner, tried to cross with the balloon. The balloon was not crossing, the guide liner was coming out. So we did a lacing, saline lacing and blood lacing. And after that, the patient developed chest pain. So this was our fourth case. So little we were panicked because patient developed. So even though EGFR is less, I just checked that. Later, when going through reference, we know that laser can produce chest pain because of that heat and the tissues. And so this is first check we had, and after that balloon escalated, the balloon was able to cross. Initially the balloon which was not able to cross, the laser has modified the tissues and balloon was escalated, and finally 2.53 NC balloons, and then the OCT was taken. So saline OCT, you can see that you can see the work done by the laser. See, these cuts are all laser with balloon. So which was not a crossable initially, we were made crossable by the laser. And also if you see that there is under expansion of the, compared to the lower one, where it is 3.23 and 3.65, in the mid it was 2.81. So the midpoint was under expanded, and there is a calcium. If you see carefully here in this spot, you can see that calcium just outside and also inside the stent. So the lacing would have helped here in handling this calcium, and then I did lacing with blood lacing, and then finally 3.5 aperta, and then 48 stent Zines expedition was placed, and this is the final result. So there was some under expansion shown 80%, and that was optimized, and this is the final result of this patient. So totally we had taken 4 shots, less than 20 ml. The patient creatinine worsened, but then it reversed after 5 days. He had a 7-day stay and gone. So the big issue is always in elderly and all these things, renal contrast is very, very important. This is a final osteoproximal LAD ISR. You can see this guy, 62-year-old male, who had a stent, and then a proximal LAD, there was a ISR, and this was angio. And this is a OCT. You can see that in that is a homogeneous mostly ISR in the segment. So we felt that, and there is also calcified segments were seen. You can see here the calcium from 6 o'clock, and so the lacing was done with 40-40 energy saline lacing. Then it increased energy to 60-40, and then since inside the stent, contrast lacing was done with 80-60, and finally that was a check. And if you see that it has there's well work with the debulking is the very important aspect with the laser, because the acute lumen gain in ISR, if you feel a homogeneous tissue, better to do laser, do a good debulking, and put a deb and come out. If there is no peristent, that is the edge of the stents are good, proximal and distal edges are good, we can avoid another stent, metal inside that. So prepared with scoring balloon and final OCT. So then we did a deb, and that was a final check. So what I want to tell me here is the thrombus, mainly what we feel is in acute thrombus situations, we had some 4 or 5 cases, young male and all, 27-year-old male, 3 days antral MI, but RCA showing collateral to LAD viability. All these cases, it was very helpful thrombus. We do, even once you do 2-3 times process of saline lacing, then you do aspiration, it was very easy to get a thrombus aspiration. Probably this modifies the thrombus and all, I don't know, we have to see that. And also in balloon uncrossable lesions, we have 2 cases. We were able to do that with balloon non-crossable lesions, and today we had 2 cases workshop, and first was a calcium, 360-degree calcium, contrast lacing was done with Wacinski Professor guidance, and he was saying that we escalated first with blood lacing, 25-75, 50-50, and finally was able to achieve good results. And in ISR, if there is a edge restenosis, or if you have neoatherosclerosis, one stent is there, better to put another stent, that's a second stent layer is there. But if it is within the stent and homogeneous like what I presented, I think you do a good lacing, shave off all the tissues, and Just dilate. No need to aggressively dilate with scoring balloons or cutting balloons after lacing, because it modifies the tissue, and we were able to do with just NC balloons and come back and dip. Thank you so much. So I call upon next Professor Wacinski to present a guest lecture. Welcome, sir.
First, congratulations, very nice cases, and thank you very much for invitations. I'm very happy to be here, and I would like to share my experience about laser in difficult cases, but I think that it will be just a show review about laser, because you know already here how it works, you know about the system, but for audience I would like to show how it works. Please go on. Okay, excuse me. It's not works. Okay, it starts. Okay, go. It starts. Okay. It's increase your understanding of laser atherectomy basis. It's my topics, and maybe like that. It's a laser system. What you know is very well here. Some laser catheters. It's a laser what we use today, 0.9. Okay. Other catheters are less used. Maximum settings in 80/80. It's very good catheter. 1.4 is less popular, as well as 1.7, what I said. In 99% cases, only 0.9 catheter is very good. First, breaks molecular bonds, cracks hardened tissue with a sonic wave, and the third, you will see cavitation phenomenon, which debulks the lesion inside of a vessel. We have three modalities. In fact, you see just a catheter tip. Step one, ultraviolet lights, and here you see the pulses. Light UV pulses breaks molecular bonds and makes a sonic wave. It's like IVL, exactly. You have one tool with a tool. It's a very nice scenario about contrast. You see. With a contrast media, your syringe it's like a hammer-like effect. Saline solution, you see only light, What happens with saline? Nothing, like a sonic wave. But with pressure sonic wave, when you have a contrast or we have blood, you increase your effect up to 50 to 125. Slow advancement, fast advancement. You see, slow advancement, you create the lumen, slow lumen, but big lumen, but fast advancement, only the slow lumen. You see yourself the same scenario like you have at your cath lab. And you have UV light and a sonic bond and cavitation. Non-dilatable, non-crossable lesions, what you have presented nicely a few cases before, under the expanded stance as well. It's a top clinical indications, as well like diffuse ISR. Okay. What we discuss also about the calcium. Calcium, calcified, heavy calcified as well is very good for lasing with non-well expanded stance. Lasing with contrast and, of course, very good results. It's a CTO, turn peak, not crossing. But don't worry, you have already your wire. After you put simply the laser, you see 360 degrees as well. It's crossing very well. It's very fast procedure. It's very fast procedure, really, for CTO. And LK catheters work with standard guide wire. It's very important. I stop here because it will be much more longer, but I just recapitalize what we can do with laser. Non-crossable lesions, non-dilatable lesions, CTO, non-well expanded stents as well, and also calcified lesions, and as well as calcified nodules. It's very important because it's very difficult to deal with last lesions, but it's only possible with blood, like a medium for laser, not saline but blood, like first escalating step. And the second escalating step, what we have made together today, contrast media, 25%, escalate to 50%. Escalation is a very good approach. Why? Because it's safe. If you are good and your result is good with blood, it's okay. You stop with a blood and you conclude with balloon and standing. If it's not good, you escalate up to 50%. It was today. It was a very good choice of a patient. And of course, always you must make visualization. If it is OCT or IVUS, never mind. Personally, I prefer IVUS, what I said today, because you see much more outside of a vessel wall, okay? Because in the calcified nodules, in the calcification outside of a vessel is very important. OCT, it's a perfect when you see inside of a vessel and just a tiny part of a vessel wall, because the resolution is perfect, for example, for thrombi, etc. It's a perfect tool. But if we are dealing with a very heavy calcification, you must see outside of a vessel wall as well. And what's else? Visualization. Okay. After lasing, you don't need to use scoring or cutting balloons because you have already modified that plaque. You have presented the cracking lines after the lasing, but also lasing make the tissue softens, the tissue inside and outside of a stent or vessel wall. It makes micro crashes. You don't see even if OCT. And this situation, you can put your stent or balloon much more easier and well expand. It's a very important. If you have a scenario when we have, for example, 2 or 3 layers of stents, of course, it's not a good idea to put 4th or 5th layer of stent. You agree? In this case, your scenario with drug-eluting balloon, it was very good. We have presented one case here. It's a very good solution, except proximal LAD, what we have made today, but it was only one stent layer because approach with laser is much more aggressive. You completely destabilized the plaque. It's better to put small stent if you have 3 layers, just a spot in a place when you have had a lasing, just like something which give you the drug into the vessel wall. In my lab, I use one of the stents which is a drug-eluting stent, but without polymer, with our abdominal drug outside of a stent. It's very good. Why? Because it make endothelialization rapidly, and you give you the drug only outside of a stent, let's say it in the right direction, okay? It's worth to have one of these abdominal coating stents without polymer. It's a direct drug on the metal. But you will try to find very easily. It's not a problem. Finally, I think that just to summarize, laser is not a skyrocket technology. It's not something for all things and all patients, okay? It's for selected patients, very difficult patients. And if you use it very wisely, it will be very, very useful tool in your lab. especially for a very difficult patients. And it facilitates the procedure. Its procedure is safer and faster. As we discussed with Professor, that faster procedure is better for a patient, because if you have very, very long procedure, you can try to find difficulties. And I think it's a good approach, and hope that in the future the laser will have also another interesting indications. For moment we have coronaries as well, and also for a peripheral. It's the same machine, the same, let's say, practically the same catheter, and of course remove the lead after the pacemaker. Thank you very much once more for attention. Thank you very much for invitations. And
Most of us have problem with calcific nodule.
yes.
Approach to calcific nodule with laser.
Yes, the calcific nodules, it's a very big problem, and for many years it was not a good solution. Actually, the best we have two, because rota is not a solution. One solution is orbital, and the second solution is a laser, and third solution is IVL. But problem of a calcified nodule, it's a problem of energy. This nodule is normally outside of a vessel wall. Yeah. And you need much more energy to disrupt this calcium nodule. Orbital atherectomy needs a special wire. It's like a rota. Okay, it's complicated. If you have some problems, you must change a wire. It's not so efficacy like other means. IVL, it could be useful, but you must know that it's a very bad profile for a moment. And the second, the energy, maximum energy, what you can reach with IVL is 50 bars, just towards of vessel wall, ultrasonic energy. As I presented before, with a laser and lasing in media like blood or contrast mixed, respectively, you can reach 50 bars, up to 70 bars with a blood, it's a more with IVL, up to 120 bars with a contrast mixed. 120 bars, it's a huge energy. And this energy is propagated just not towards of the catheter tip, but just around the catheter tip, okay? And if you have, for example, catheter 0.9 and your vessel is 3.0 and your catheter is just in the middle, it means 1.5 distance from a catheter tip to the vessel wall. And with contrast mixed, you can reach, in this scenario, 100 bars outside of a vessel wall. It's a very powerful, and in majority of cases, I don't say that it's a 100 cases, there is no technology 100 cases, but in 90-95% of cases you are successful to disrupt this calcium in calcium nodule, because our mission is not to remove this calcium. It's not possible, and even it will be worse. Just to crush, to allow to expand the balloon to the diameter what you want, and make the stenting after. It's all. That's all.
How common is perforation, sir, in calcium?
Yes, good questions. Because perforation, it was an issue 15 years ago, as well as rota. And now it's not an issue. A Rollcaster study, it was published 1 year ago. It was comparison, it's a new study, new approach, new PCI. It was published, and it was comparison between ROTA, IVL, and laser in terms of efficacy and as well in terms of side effects and in terms of complications. There's no significant difference now between these three modalities, ROTA, IVL, and laser. If you obey the rules, what I presented, what I discussed with doctors today, first, saline, second escalate, it's blood, and the third escalate, it's a contrast mix, but it's not for simple cases. If you have a lot of calcifications or you are inside of a stent, it's absolutely safe. If you don't have calcifications, don't use laser with contrast, okay? In this case, in this scenario, you don't have a problem. But of course, it could happen. In my personal experience, I did over 10,000 PCI in my life. I did much more perforation with a normal ballooning in a calcified lesions, of course. But what for? Okay, don't be panic. You know very well. You put your balloon, you wait. You give another stent, or give a cover stent, or you block heparin by protamine. That's it. That's all. Dissection, of course, you can expect dissection because it's aggressive. But dissection you also provoke your balloon or your other devices. But it could happen, of course, but it's not much more like with other devices.
We should be prepared for the complication. We should have everything in the shelf.
The shelf?
We should be prepared for the complications.
As of course, you must be always prepared for complications. It's a reason why I said which approach is simpler and this approach is safer. If you use too much devices, which each devices you multiply the problems, potential problems, you know. It's a reason why I said if you're lasing, don't use scoring balloon or cutting balloon. It not make really sense. If you use it, don't use laser. Use cutting balloon and conclude with a balloon. But sometimes it's not possible. But anyway, for complex cases, it's an excellent tool. For very easy cases like type A, don't use laser. It's not worth to do. Really, it's for a selected cases. It's not a miracle. It's just a tool which produces so much energy to help to debulk the lesion. Today also the second case, it was ISR case that you can remove the plaque from inside with neointima formation, what you presented tonight, and just when you put the second stent, your sandwich is very tiny, you know, and it's a good result because we remove the majority of tissue. You have discussed with me today why remove all of the tissue. Yes, okay. You can put the bigger catheter, but you create the risk of perforation. Okay, you see. It was like with ROTA. When several days ago we started ROTA with the 2.5. 2.5 makes problems, make troubles, make perforations. When ROTA was relanced 8-10 years ago with smaller bar, and the proposition to start 1.25, 1.5, not 2.5. And now it's the same level of safety with ROTA, laser, and IVL. It's your choice, of course, like operator. It's your choice, of course, like operator, which tool you use. But it's good that you have a choice. If you have IVL, ROTA, orbital, a laser, for different scenario, but you are prepared. You can choose, okay, this case is for ROTA, but this case is for laser. No. Thank you. Thank you very much, Asmo. You want?
Okay. Yeah, so. So.
Sir, Ganeshan sir, please. Vaanga sir. Vaanga, come, please. Sir, please vaanga sir. No, please. Illa sir, vaanga. Please vaanga sir. Sir, it's an honor for us. Also invite Dr. Selva Kumar to the stage, please. Sir, vaanga sir. Sir, you want to... Dr. Manikandan. Dr. Karthik, please. Dr. Karthik, please. Sir, photo எடுத்துக்கலாம் சார், அங்கேயே இருக்கேன் சார். Dr. Venkatesh, please. Sir, vaanga. So request everyone to be on the stage. We'll take on group photo, please. Sir, vaanga sir. I think I request everyone, all maybe all Aruna team அப்படியே வந்திருங்க. எல்லாம் வாங்க.
வாங்க எல்லாம் வாங்க அருணா டீம் வாங்க.
இவங்களாம் ட்ரைனிங்ஸ் ட்ரைனிங் இன்னும் போக படிக்காமல் நீங்கள் கோமாளி ப்ரோ யூரோப் யூரோப் அது யூரோப் யூரோப் பெரிய தலை $1 வாங்குறாரு. அங்கே டாலர் பிளேயர் அது ஹீரோஸ் ஹீரோஸ் தானே. நம்ம நாட்டு மதிப்படி அங்கே ஒரு ஹீரோஸு $203 அங்கே அங்கே ஒரு ஹீரோஸ் இங்கே $203. அவர் அங்கேயே $2 லட்ச என்ன ஆகுது பாருங்க.